Hi, friends. Thank you much for watching the medical education channel. I'm Salah Abbas. Um, Today I chose an important topic in general surgery, and that's anal fissure. A very common condition that you will see in your clinical practice. And I want you to grasp the basic ideas and principles of the disease and its management. Now, before we go on to talk about anal fissure, I need you to be aware of the possible causes of perianal pain. So the painful perianal conditions, there are a few of them, but on top of the list is anal fissure, the most common, followed by perianal separation, such as a perianal abscess, a rectal abscess, and the fistulas that could follow on these separations. There is a problem called thrombosed external pile. Typically, this is like a hematoma around the anal verge in a young man who is usually a laborer with heavy lifting or standing for a long time. As a result of lifting something heavy, you could rupture one of the hemorrhoidal veins and lead to a painful condition. It's usually self-resolving after 5 days. The other reasons are if the patient have got prolapse hemorrhoid or prolapse, particularly if they are strangulated hemorrhoids. That's common condition for perianal pain. A patient with Crohn's disease can particularly suffer from perianal pain and perianal fistulas. The same thing could happen with proctitis or patients with ulcerative colitis. Even in the absence of other pathology, they would have a lot of perianal pain. Fecal impaction is a very important problem, and that can happen, in fact, in children and in elderly are also the other group of population that can have this type of problem. Now, how do they present? In a nutshell, these patients usually come to you young, relatively, most of them, with a painful condition. Usually after having a bowel motion, they have been constipated, and usually the pain stays there for about half an hour, and it's a sharp pain, and then the pain eases off after about 30 minutes. It is a typical presentation for acute anal fissure, but anal fissures can be chronic as well. Good. Now we go to the presentation in a bit more details. So when these patients come to you, the first thing is that I avoid digital rectal examination because it's extremely painful. Just by spreading the cheeks and you look at the anal area, and you will see a longitudinal ulcer, and that longitudinal or linear ulcer is in the lower half of the anal canal. You know the anal canal, if you look at the picture, we've got the dentate line here. We've got the transitional epithelium in here, and then mucosa. Below that, it's the anoderm, which is supplied by cutaneous nerves. It's extremely sensitive to pain, and if you do digital rectal examination, that will inflict a lot of pain on the patient. So it's only inspection. Majority of these fissures happen at 6 o'clock position when you are looking at the patient in a lithotomy position, which means posterior. Usually there will be a few drops of blood that the patient passes with the bowel motion, which is usually constipated, and then that blood is stops. Could be just a small splash in the toilet bowl, or a few drops on it, or just when they wipe their bottom, they see some blood on the toilet paper. And when the fissure becomes chronic, you will find that there are two things that will happen. One of them is called sentinel skin tag, and it is just a skin tag that happens at the lowermost part of the fissure, and there will also be a hypertrophied anal papilla, and the anal papilla sits at the anal the squamocolumnar junction, and here the transition point between the squamous mucosa and the the mucosal lining of the upper half of the anal canal, and it looks like that in the picture. If you look at that enlarged, prominent anal papilla, these are particularly common in patients who have chronic fissure or chronic with acute exacerbation of fissures. As we said, these patients tend to be constipated. Always when there is perianal pain, beware of Crohn's disease. Think about it, because that can defy the clinical assessment. So you need to be aware of that. It can lead to perianal sepsis, which could be deep and not obvious on the skin, and the patient will suffer from chronic or acute perianal pain. So in a nutshell, that's how they present. I better explain to you the pathogenesis of the anal fissure. What happens? How does it happen? Usually, a patient is constipated, passes a large, hard stool, which will stretch the mucosa and lead to a crack or linear ulcer in the lower half of the anal canal, distal to the dentate line. That can be that can also happen in women during childbirth. People who are constipated and do laxative abuse, because a large motion could pass as a result of that after constipation and could lead to tear of the anoderm. Now, once that happens, there is a vicious cycle that could take off. Because of the ulcer, the internal sphincter will be very tense. So there is increased tension if you measure it on the manometry in the internal sphincter. And as a result of the increased tension in the area, which is the resting tension of the anal canal, then that leads to ischemia of the area, which will hamper the healing. It will prevent the healing, and the non-healing leads to pain, and the pain leads to more spasm, and so on and so forth, until you treat the problem. So the sphincter hypertonia is supposed to be, or thought to be, the cause of non-healing of the fissure and also the recurrences. Very good. Now, how do we manage them? The majority of these patients will be managed non-operatively. And if they are constipated, we advise them to use laxatives, usually bulk-forming agents. We give them pain control, advise them to use sitz bath, and that's the traditional treatment for acute anal fissure. There are topical agents that can be quite useful, such as proctocidal, that is soothing agent, which has got some steroids in it and some lignocaine. That's a soothing agent and usually helps with the pain until the fissure heals. And by these simple measures, the laxatives, the pain control, the sitz bath, and the use of the topical agents will result in healing in almost 90% of the cases, provided the patient doesn't become constipated later on. There are other medications that we can use, and they seem to be effective. The glycerin trinitrate, it's the same medicine that you use for angina, is very effective. It's a smooth muscle relaxant. It's a nitric oxide donor that leads to relaxation of the anal sphincter and allow the fissure to heal. In a similar way, other medication can work, such as calcium channel blocker, the diltiazem and the nifedipine. And another form of treatment which is in favor these days is the Botox injection, where they get about 20 units of Botox, and they divided them in half and inject them on either side of the anal area in the internal sphincter level. Otherwise, it won't work. The problem with all these medications and with the Botox is the probability of recurrence, unless the patient improve their diet and avoid being constipated. Now, if it recurs or doesn't heal after a few weeks, then we call it a chronic anal fissure. The addition of smooth muscle relaxant has been shown to lead to healing of the anal fissures in about 70% of patients. The results are probably better with the Botox, but the Botox has got a small risk, and the risk that happens with it is incontinence to gas, and that's usually temporary though. And the other problem is that if the patient remains constipated, then we have the long-term recurrence. But we use it for mainly for women because of the risk of incontinence in surgery. So it would be a good indication for it in ladies, and also in patients who refuse to have surgery or they are not suitable for surgery for medical reasons, for other comorbidities. And the last resort is surgery. We keep surgery as the last resort for the treatment of anal fissure. So the surgery is called lateral sphincterotomy, which is division of about a centimeter of the internal sphincter at the level of the fissure. Now, the procedure is simple but need to be done under general anesthesia. Patients who fail medical treatment, they get offered lateral sphincterotomy. Patients who have recurrences of fissure, they will be suitable. And some patients would not tolerate GTN because GTN can lead to throbbing headaches, and some patients do not actually tolerate that at all, and they can't use it because when we use the GTN, we ask the patient to use it for about 4 to 6 weeks, similar to the other ointment. Also, 4 to 6 weeks time for the ulcer to heal. Now, lateral sphincterotomy comes with a risk of incontinence, particularly in women, and that's why we favor Botox in women over surgery. And the lateral sphincterotomy, I think you can see the picture here. The surgeon with his instrument have divided the mucosa, the pink area, and exposed the internal sphincter. And the internal sphincter is white fibers. And then he will divide the internal sphincter for about a centimeter along the lateral side of, usually lateral side of the anal canal, which is either 9 o'clock or 3 o'clock. That procedure is particularly useful to heal anal fissures, and majority of the anal fissures will heal with this, and it's estimated that almost 90% of them will have no recurrence. There is another treatment which is called mucosal advancement flap. Now, I mention this because you might come across it. We don't use it very often, but some patients, if they had previous hemorrhoidectomy or they have scarring of the anal canal from perianal sepsis or other reasons, they could have anal stenosis, and the anal stenosis by itself can lead to formation of fissures. And in this situation, we do a mucosal advancement flap, and that either as a simple advancement flap or a VY flap, simple to do and usually is successful. In the past, fissure excision was thought to be useful to enhance the healing. The truth of the matter is that it does not, and it's been more or less totally abandoned. So that's what I have for you today. It's about anal fissure. Nice and simple. You've got the presentation, you've got the causes of it, you've got the differential diagnosis, and then we went through the pathogenesis of the issue. How do we treat acute anal fissure, and the treatment of non-healing chronic fissure, and the role of surgery in this particular situation. Thank you for sticking with us to the end of the video, and I will see you in the future lessons. Thank you much.